Okay. Um, Thank you very much for inviting me to present this work today. I, uh, I apologize for being sort of congested, but let me reassure you all that it is just a head cold. We have verified that. Um, so, um, so today I'm going to be talking about some work I'm doing with colleagues at the University of Southern California and UCLA that's looking at the effects of Medicare Advantage on post-acute care. Did everyone see my slide just change? Good, okay. So this graph may look familiar to you all from the last presentation. So just to motivate the importance of Medicare Advantage, as you all know, Medicare beneficiaries choose between enrolling in traditional fee-for-service Medicare or in a private Medicare Advantage plan. And the percentage of Medicare beneficiaries that have chosen to enroll in Medicare Advantage has really increased rapidly over the past decade or more. But on top of that, the Congressional Budget Office released some projections last year that estimates that Medicare Advantage enrollment could be up to 47% of Medicare by 2030. So if this trend continues, it's going to be half of the Medicare program. So it's a really important question to sort of understand how Medicare Advantage works. So I just want to walk through some of the trade-offs that surround Medicare Advantage, and I'm sure this is all pretty familiar to all of you. So it is definitely the case that Medicare Advantage plans have incentives and tools that allow them to control healthcare utilization and reduce the cost of healthcare relative to traditional Medicare enrollees. So Medicare Advantage plans receive a monthly capitated payment, and they are essentially keeping the funds that are left that are not used on patient care. So this creates a strong incentive for them to avoid unnecessary healthcare use and manage the care of their enrollees. Medicare Advantage plans also have flexibility that really isn't present in traditional Medicare to manage utilization. So, for example, they are allowed to establish narrow healthcare provider networks so that their enrollees can only go to certain providers and have that care covered. They have the ability to use prior authorization to, requiring that enrollees receive permission to use different kinds of healthcare. And then finally, they have flexibility in the way they design their health insurance benefits and the types of services that they cover that can, point, for example, patients to receive case management or telemedicine services that could avoid some kind of downstream healthcare use. So they can sort of innovate in different types of areas. Now, when it comes to the quality of care and patient outcomes, at a high level, there are sort of conflicting incentives for Medicare Advantage plans. So on the one hand, the quality, performance on quality measures is publicly reported for Medicare Advantage plans, and plans under the star rating system, MA plans receive financial bonuses for high performance. But at the same time, there is this incentive to constrain costs and manage healthcare use. And if the healthcare use being curtailed is just unnecessary care, then this is not a problem. But if certain types of beneficial services are curtailed, that could actually harm. That could have negative effects on enrollees' functional or clinical status. So, evaluating the effects of Medicare Advantage on costs and patient outcomes is difficult because it's a voluntary program. So there's a lot of cross-sectional evidence. I think one of the most comprehensive recent papers is by Curto et al. From 2019. And generally, it shows like strong evidence that Medicare Advantage plans have lower costs and less healthcare use, but mixed differences in terms of quality of care relative to traditional Medicare. But these kinds of cross-sectional studies really face two key challenges. So one is that this favorable selection. So Medicare Advantage plans have a strong incentive to enroll individuals who are healthy. I mean, this happens both along observed health status, but also even conditional on unobserved health status. And also, because of the way capitated payments work, Medicare Advantage plans are paid more if they code more diagnoses for their enrollees. And so as a result, you get this more intensive coding of diagnoses for Medicare Advantage enrollees relative to traditional Medicare enrollees. And so making a cross-sectional comparison and controlling for health status is problematic as a result. And so generally, there's really fairly limited causal evidence on the effects of Medicare Advantage. There are a couple of more quasi-experimental papers. So one from 2019 looks at the exit of the only MA plan in some counties in New York and finds that there are fewer hospitalizations under a Medicare Advantage, but no higher mortality. And another paper looked at variation in payment thresholds depending on how large of a metropolitan area you're in, and use that to get exogenous variation in Medicare Advantage enrollment. That paper also found lower use of hospitals and hospitalizations and mortality. So the causal evidence to date does sort of show more efficient care without an adverse effect on quality. So in this paper, we're really trying to build on this causal evidence of the effects of Medicare Advantage. And so what we're doing is studying a policy shift in Ohio in 2016. So retired state workers in Ohio in 2015 had to receive their health benefits through a Medicare Advantage plan that was sponsored by the state. But then in 2016, they shifted that benefit to be subsidies for enrollee or retirees to choose a Medicare Advantage plan or a supplemental coverage for traditional Medicare on a health exchange that they set up. And so what you see is that in 2015, anyone with sponsored retiree health benefits were in Medicare Advantage. But in 2016, only 27% of retirees were in Medicare Advantage. And so we're using this as a source of exogenous variation in Medicare Advantage enrollment to study the causal effects of Medicare Advantage. And so we're looking at specifically post-acute care. And so this is an area, so this is inpatient rehab or skilled nursing care that a patient receives after a hospital stay. And there's really little causal evidence on the effects of Medicare Advantage on post-acute care use to date. So it's almost totally been cross-sectional evidence. And so what we're going to do is look at how post-acute care and post-discharge outcomes changed when Ohio public retirees shifted away from Medicare Advantage compared to different comparison groups that were continuously enrolled in Medicare Advantage or traditional Medicare. So again, the obligatory preview of results in case my Zoom crashes. So we find huge relative reductions in Medicare Advantage enrollment for Ohio public retirees in 2016 relative to our different comparison groups. So this is kind of our first stage. We find evidence that after this change happened, there's small evidence or sort of mixed evidence that Ohio public retirees, once they were in traditional Medicare, were more likely to receive any post-acute care. And we find stronger evidence that if you receive post-acute care under traditional Medicare, you were more likely to receive it in a more expensive and intensive post-acute care setting. which I'll go through. But we found little evidence that this led to any kind of improvement in the patient outcomes we're able to look at. Okay. So I'll just give a quick overview of the talk. I'm going to discuss public retiree health benefits and post-acute care. I'll go through data and methods and results, and I'll include a little discussion. Okay, so let's talk about public retiree health benefits. So retirement health benefits are less and less prevalent for private sector workers, but public employees still often receive these kinds of health benefits. And so there are different ways that Medicare eligible employees would get benefits across states. So one approach is to provide a Medigap supplemental plan for traditional Medicare. So this covers the substantial cost sharing that's required under traditional Medicare. Another approach is to sponsor a Medicare Advantage plan. So basically, the plan is just offered to state retirees, and then the state helps with, premium contributions. And then the third approach is to provide subsidies for retirees to purchase a Medigap or Medicare Advantage plan. So as I'm sure you all have kind of read about, states are feeling a lot of fiscal pressure with these retirement health benefits and pensions being underfunded. So more states are shifting to either Medicare Advantage plans or subsidies, in part because the financial risk is much lower, because basically the state is not the residual claimant under an MA plan or the subsidies. So like the MA plan would be the residual claimant, but these supplemental plans are usually self-insured. So the state is basically going to be responsible for really high healthcare costs. And so basically shifting and retiree health benefits is creating, we would argue, variation in Medicare Advantage enrollment that is not going to be biased by, related to other individual attributes that are related to healthcare use. And then one other point is that, is this representative of Medicare beneficiaries as a whole? And state workforces are huge. And so it is you get a large sample of Medicare enrollees. And state workforces really, it's interesting when you read these reports about just documenting the types of employment categories that comprise state workforces. Like, it's a really broad range of professions and education requirements. So, more kind of management, white collar positions, but a lot of, other types of positions as well. So we would argue this is like a good, fairly representative sample to look at for understanding the effects of Medicare Advantage. So this is the change in Ohio that we're studying in this paper. So the left panel shows the sort of 2015, this comes from the Ohio Public Retiree Benefits Package. And so in 2015, for people who wanted sponsored retirement plans from Ohio, the Humana Medicare Advantage plan is the only medical coverage choice for Medicare eligible participants at retirement. But in 2016, the state no longer sponsored this plan. And basically they were able to select a Medigap plan or a Medicare Advantage plan and a Medicare Part D plan using this connector system that basically displayed public options for retirees. So our analysis, we're going to do a differences in differences analysis. And this is going to measure the intent to treat effects of these changes in Ohio in public retiree health benefits. So our treatment group here are Ohio public retirees from 2015. And so we're going to identify this group because we know the contract number for the sponsored MA plan. And so we can find these people in the data based on that MA plan enrollment in 2015. And I think one key point about this treatment group is that it only includes, so the public teachers and public university employees in Ohio are in a separate plan. So I think the benefit of that is we would think of that as being a more, probably on average, a higher SES population. And so hopefully this gives us a more representative population in our analysis. So then we have 3 different comparison groups. Our first comparison group are people who are enrolled in other Humana Medicare Advantage plans in Ohio in 2015. And so this is going to give us basically a counterfactual for people who stayed in Ohio Humana plan from 2015 to 2016. So we don't actually just focus on people who stayed in the plan in 2016, but most people did. So so with our intent to treat, that's how that's working, but that's the idea. Our second comparison group are people who were in traditional Medicare in 2015. So this is kind of a reverse difference in difference. So basically we're comparing, people who changed from MA to traditional Medicare, the public retirees, to people who are just in traditional Medicare. And then our third comparison group, you might think that public retirees are, different from the general population. So we found a neighboring state, Kentucky, and their public retirees were in a mandatory MA plan from 2015 to 2016. So hopefully this is sort of matching along, like, public retirees to public retirees, more apples to apples comparison. So this just shows you enrollment in Medicare Advantage for each group and year. And so when you look at the treatment group, clearly there was a huge reduction in Medicare Advantage enrollment from 2015 to 2016, going from 100% to 27%. When we look at the first comparison group, there's some attrition from Medicare Advantage, but in 2016, still 91% of people were enrolled in Medicare Advantage. Looking at the second comparison group, the traditional Medicare enrollees, some switched to Medicare Advantage, but pretty small percentage. And Kentucky public retirees stayed pretty continuously in Medicare Advantage. Okay, so I want to give a quick overview of post-acute care. So this is rehab, nursing, and other services that after a hospitalization. So Medicare spending on post-acute care really exploded during the 1990s and 2000s. And so in 2016, this was 9% of total Medicare spending. And so there's a sense that maybe it's being overused. And so, currently there are these traditional Medicare policies that are targeting post-acute care, and spending has leveled more recently. But that's just important context. Like, there's a sense that this is being provided sometimes in ways that it is not necessary. So when we think about, so this paper is really focused on institutional post-acute care. And a key thing is that a particular patient, for example, in this case, I'm talking about a stroke, could be discharged and receive sort of somewhat comparable care in different post-acute care settings. So one setting is a skilled nursing facility, and these facilities are equipped to provide pretty intensive levels of therapy. But then there's another type of post-acute care facility called an inpatient rehabilitation facility. And these facilities provide more intensive therapy. So they have to provide a minimum of 3 hours of therapy per day. But it's quite a bit more expensive. So MedPAC did an analysis, the Medicare Payment Advisory Commission did an analysis and found that for some conditions, and for many conditions that they looked at, inpatient rehab care was more expensive than skilled nursing facility care. So what is the effect, what are the potential effects of Medicare Advantage on post-acute care? Well, under traditional Medicare, post-acute care providers are paid either an episode payment for inpatient rehab or per day payments for skilled nursing facilities. And this creates an incentive to provide more episodes of care and longer skilled nursing facility stays. In contrast, Medicare Advantage plans are paying for post-acute care out of a capitated payment that they're receiving from Medicare. And this creates some strong incentives to use less post-acute care because they're keeping the remainder. And so their Medicare Advantage plans are contracting individually with post-acute care providers, and they're much more actively managing the use of post-acute care. So that brings us to our potential hypothesized effects of Ohio public retirees shifting from Medicare Advantage to traditional Medicare. So first, this could result in overall higher use of institutional post-acute care as they move to traditional Medicare where this is not being managed as closely. Second, there could be some switching back towards more intensive and expensive inpatient rehab relative to less expensive skilled nursing. And to the extent that receiving more intensive post-acute care is or is not clinically beneficial, this could affect patients' post-discharge health outcomes. So I want to briefly talk about data. Another challenge with studying Medicare Advantage is that it's difficult to get information on healthcare use. It's becoming more available, but it's still not as comprehensive as traditional Medicare. So we're using this fact that hospitals that receive certain kinds of educational subsidies or subsidies for having lower income caseloads are required to submit encounter claims for Medicare Advantage. Our estimate is that these hospitals comprise about 93% of Medicare discharges. So it's like most hospitals and really the important hospitals. We use enrollment data to identify source of coverage, some patient characteristics, and mortality. And then to get information on skilled nursing facility stays and inpatient rehab facility stays, we use the fact that these facilities have to submit patient assessments for all patients, regardless if they're traditional Medicare or Medicare Advantage. Our study population includes, so our kind of unit of analysis is a initial hospital stay and then a 30-day post-discharge episode. And we do this so basically these are hospitalizations and post-discharge periods for the treatment and comparison groups from 2015 to 2016. We're focusing on hospitalizations for 10 conditions that have like really high volumes of hospitalizations. And we divide them into two categories. So the first category are conditions that Medicare deems like requiring intensive rehabilitation. And so these are conditions that actually count towards an inpatient rehab facility being certified as an inpatient rehab facility. And then we have the second group of lower rehabilitation conditions. And we identify these conditions based on the Medicare severity related group that we see on the initial hospital claim. So briefly talking about the study measures, we're looking at any inpatient rehab use, only receiving skilled nursing facility care, days in a skilled nursing facility, and also receiving any institutional post-acute care. Our outcomes we're looking at include 30-day hospital readmissions, as well as residing in the community for all 30 days after discharge. And it being a diff and diff, our main explanatory variable is being a public retiree in 2016. And we have a bunch of control variables as well. So our main regression specification is a pretty standard diff and diff. We look at outcomes for patient's eye from treatment or comparison group, from a hospital and each quarter. We include hospital and quarter fixed effects. Our controls include age, gender, race, ethnicity, and Medicaid enrollment, and also the DRG from the index stay. And then our main coefficient of interest is the relative change in post-acute care or a post-discharge outcome for public retirees versus the comparison group. Okay, so this table is just showing the characteristics of hospitalized patients in our sample across, so the Ohio public, this is our treatment group, this is our first comparison group, our second comparison group, and our Kentucky third comparison group. And so what you see is that, like, along the measures we can observe, these groups are like pretty comparable in terms of age and gender. The key difference, I think, is that there are some differences in race and ethnicity. And I think the biggest difference is that the Ohio public retirees and the Kentucky public retirees are much less likely to be enrolled in Medicaid, which kind of makes sense because you're getting a higher part of the income distribution with public retirees. But we do control for Medicaid status. So this sort of shows it's a graphical display of our first stage. And so what you're seeing is that, you know, this is similar to the other graph I showed. So the first comparison group is the blue line, hospitalizations before and after the change in public retiree benefits were mostly covered by Medicare Advantage. The red line, comparison group 2, this is pretty continuously being covered by traditional Medicare, but you see a huge reduction in hospitalizations for people covered by Medicare Advantage for Ohio public retirees. So this is the variation we're studying in our analysis. Okay, so I just want to walk you through the key finding of our paper here. So this plots the percentage of hospitalizations that receive inpatient rehabilitation facility care in 2015 and 2016 and the two main control groups. So you see here, the blue line includes Medicare, the Humana Medicare Advantage enrollees in Ohio who aren't public retirees. The red line shows use of inpatient rehab by traditional Medicare enrollees. And so you see that, like, the percentage of traditional Medicare enrollees using inpatient rehab facilities is much higher than Medicare Advantage enrollees. And this is pretty consistent with cross-sectional evidence from prior work. So now I'm going to overlay on that Ohio public retirees. And there's just like a you know, such a switch. So in the pre-period, when they're in Medicare Advantage, their use of inpatient rehab facilities is very similar to other Ohio Humana Medicare Advantage enrollees. But then when they switch to traditional Medicare, or most of them switch to traditional Medicare, their use of inpatient rehab is very similar to traditional Medicare enrollees in Ohio. And so you're seeing this big shift in post-discharge care. I'm going to do a similar display of the percentage of enrollees receiving only skilled nursing facility care. Here, the Medicare Advantage enrollees are more likely to receive just skilled nursing facility care. The traditional Medicare enrollees receive less. And Ohio public retirees, it's a little messier than the first graph, but still, they're more comparable to Medicare Advantage in the pre-period and more comparable to traditional Medicare after the policy change. But when we look at 30-day readmissions, the three groups are almost identical over the entire period. There's really no clear evidence that this changed after the policy change. So this table is showing diff and diff estimates for these rehab intensive conditions. The first column shows the means for Ohio retirees, and then the columns 2 through 4 are showing the diff and diff estimates for each different comparison group. So this is, we don't combine the comparison groups, we just estimate this separately. And so first, I mean, what you would, as you'd expect from the event study figures, like there is really a pretty large shift in post-acute care when Ohio public retirees shift to traditional Medicare. So, there's a big increase in the percentage of discharges that receive any inpatient rehab. And these estimates are pretty, relatively similar across the comparison groups. And a sizable reduction in only receiving skilled nursing facility care. So what this is showing is that, after shifting to traditional Medicare, Ohio public retirees received more intensive post-acute care. And there are generally increases in the percentage of in retirees that received any post-acute care, but it's only significant for traditional Medicare, for the second comparison group. But despite this increase in intensity of post-acute care, you see no change in 30-day readmissions. And if anything, switching to traditional Medicare led to a reduction in the probability of remaining in the community for 30 days after hospital discharge. So this table shows a similar graph for the lower rehab conditions. And generally the pattern is pretty similar, although the magnitudes are smaller. You see some switching to inpatient rehab, switches away from skilled nursing, and no change in outcomes, or no improvement in outcomes for the Ohio public retirees. So just to summarize, we find that Ohio public retirees received more intensive post-acute care after this shift away from a mandatory Medicare Advantage plan. But despite this change, we find either similar outcomes or worse outcomes. And so this finding is pretty consistent with some of the prior literature, and it suggests that Medicare Advantage is providing more efficient post-discharge care. But there are some limitations of this analysis. We have the measures we use in terms of outcomes were pretty crude measures of functional status. And so there could be some negative effects that we can't measure. And this really comes from the fact that there really is no universal functional assessment that's given to everyone discharged from the hospital. And so it's just really hard to measure. Another limitation is that, this can have really negative effects on caregivers if you reduce the intensity of post-acute care. So because basically these informal caregivers like family and friends are responsible for providing therapy and helping their relatives and friends. And so that, we're not measuring that. I think there are some important questions also about mechanisms. So are these effects, are there changes in the networks of post-acute care providers that are being used before and after the policy change? And then finally, I think an important underlying question that's difficult to look at in our current data is just what's happening to the overall rate of hospitalizations after this change in benefits, because that's really our underlying denominator. And I hope that's something we can dig into more in the future. Okay, thank you.
Thank you very much, Jason, for organizing this excellent conference. And I really learned a lot so far. And it's my great pleasure to discuss this very interesting paper by Peter just presented. So this paper is trying to contribute some of the big picture issues that any economist should care about. The question is whether we should use private market to provide health insurance. And I think the answer really depends on that whether private market are more cost effective than the government. And it is actually not really obvious to answer these questions. For example, private companies may just cherry pick healthy consumers called risk insurance, risk selection. Or maybe that market-based arrangement may not be really ideal. That may happen, particularly if the market is not really competitive. And studying these issues in the context of Medicare Advantage is really important because Medicare Advantage was small in 2000, just cover 5%, but it covered 22% of the Medicare beneficiary today. So what this paper does is to provide new evidence about whether Medicare Advantage is more cost-effective than the traditional Medicare. The authors study these issues by exploiting a very interesting institutional change in Ohio, which reduced MA take-up rate among the retiree state employees and then look at their impact on healthcare utilization and health outcome. And then the finding is that healthcare utilizations, particularly measured by the post-acute care, is reduced, but there seems like no effect on the subsequent health outcome measured by some hospital readmission rate. So this result sounds like supporting that Medicare Advantage is maybe a good arrangement to like reduce inefficient spending without harming much in the economy. And I view that this is a useful addition to literature kind of studying about these issues, and particularly exploiting the very interesting variation in the data. And I think the empirical design seems to be very clean. So my main comments are the following 3 points. So the first one is the variation in the data. The second one is about the mechanism. And the third one is some of the open questions that I think are important for future work. So the paper utilized this Ohio, the policy change in the Ohio public retirees, so which were initially mandated to be given the Medicare Advantage before 2015, but from the 2016, those people are given an option to stay Medicare or move to traditional Medicare. And it seems like that both options are given some subsidy for the consumers. And the important finding and the key variation in the data is that actually most of those people switched to the traditional Medicare. For the paper that I've read, I don't see like much discussion about this policy change, but it seems really important. So I think I'd like to learn more about this, the policy itself. So I think you may elaborate why this policy change happened and why people switched to traditional Medicare. And is this kind of related to the demand for certain healthcare, or somehow state government noticed that Medicare Advantage is not really very much with those consumers? And I think this point is actually very important because this is opposite to the current trend in the growing the Medicare Advantage market. Okay, people are buying more and more Medicare Advantage, but suddenly the people in the Ohio public retirees, they all withdraw. So the question is that whether the variation we utilize in this type of setup is actually relevant for learning about like a cost effectiveness for Medicare Advantage for the broad populations. Also, that I just learned from this presentation now that it seems like that for the people who switch to the traditional Medicare, they are actually receive a lot of subsidy to buy Medigap. So this is a private health insurance. So that I think that actually potentially causes a problem about interpreting the Medicare Advantage versus traditional Medicare. For example, that people you find that actually people spend more, take a more healthcare utilization after moving to traditional Medicare, but this is not really about public insurance. Maybe this is just driven by the Medigap, a private insurance. So as a result, I now see less clear that whether your paper is actually trying to tell about Medicare Advantage versus traditional Medicare. I think the more clarification for this institutional setup is therefore very, very crucial. And also that paper estimate intent to treat effect, which is great, but I also want to see whether you can show some event study plot for the people who stay in the Medicare Advantage among those public retiree about their healthcare utilization, health outcome, whether you see no trend or not. That seems to be more convincing as well. And as Peter admitted in the conclusion, that the paper is mainly about identifying the effect on the outcome, but not really about mechanisms. And I think that to kind of contribute this current literature about this, Medicare Advantage and traditional Medicare, I think that it is very useful if you can say something more about the mechanisms, particularly how private insurer reduce the usage of the inpatient rehabilitation, admissions. It is a feature of the financial contract or some bargaining between insurers and providers and so on. So I think that providing more evidence, direct evidence on these dimensions makes, I think, paper more appealing. And also, as you said, that maybe health outcome so far is kind of quite limited just for the readmission status. So I'm also, even just looking at this health status, I'm also wondering if you see any sort of a change in the compositional change among those people experiencing the admissions. And there are some questions about external validity for the other health utilizations. And also, maybe you can say something about cost-benefit analysis as well. The last point I want to make is an open question. So this paper is very useful to kind of show that it seems like a Medicare Advantage is, reducing healthcare utilizations. However, we don't know whether this is just because private companies are good or because of some nature of the market. So particularly, we don't know that about the relationship between the cost effectiveness and the market competitions. And this is actually a very non-trivial question. If the market is more competitive, actually insurance companies have a more incentive to provide a generous health insurance contract to attract consumers. So therefore, competition actually potentially increase healthcare costs. But those additional spending for healthcare costs can be potentially useful for the consumer's health status. So the question that I think that literature is currently missing is how should competition policies be actually designed to address the trade-off between risk protection and moral hazard. And there's one recent paper that currently written by the Connor Ryan, who is on the market this year from Minnesota. The paper is about effect of insurance competition on healthcare provisions. And then this paper potentially provides an important addition to these literatures. Specifically, he studies about competition in the Medicare Advantage on healthcare spending in health. And he showed the evidence that more competition is associated with more generous insurance. And he then developed an estimate, a state-of-art IO-style equivalent model of the Medicare Advantage, which features health plan choice, medical consumption, health outcome, and also insurance product choice. And he kind of estimates this kind of complicated models using very cleanly by using this all payer claim data. And the bottom line is that the competitions measured by mergers actually increase healthcare, but also improve the consumer health. So that suggests that the competition policy is another policy lever to deal with cost control that maybe we want to think hard about this Medicare Advantage literature. Okay, so final comment. So this is a very important topic, and I think I like them also exploiting the interesting institutional change and show a very interesting finding. And I look forward to see a finalist version paper. Thanks.